This is a microbiology podcast on pneumonia and tuberculosis. Pneumonia is an infection of the lung parenchyma and may be classified according to where it was acquired. So we have community-acquired pneumonia for disease acquired outside the hospital, hospital-acquired pneumonia or nosocomial pneumonia for disease acquired at the hospital, and aspiration pneumonia following inspiration of various secretions. It's also important to consider any underlying factors predisposing to pneumonia, such as the presence of pre-existing lung disease, for example cystic fibrosis or smoking, generalized immunocompromise, which may be either primary or secondary, as well as the season, geography and presence of any epidemics. The exact clinical presentation usually depends on the organism, but most typically there is general malaise with fever or rigors, shortness of breath, cough plus or minus sputum, and pleuritic chest pain. The signs that may be elicited include pyrexia, tachypnea, cyanosis, dullness to percussion, tactile vocal fremitus, bronchial breathing, and crackles. And lastly, the most important investigations include standard bloods, such as the full blood count, urean electrolytes, and CRP, blood cultures, even though these have a low sensitivity, and sputum microscopy culture and sensitivity. An arterial blood gas is also useful, as is a chest X-ray. A useful way of bringing all of these features together is by considering the CURB-65 score, where C stands for confusion, urea stands for greater than 7 millimoles per litre, respiratory rate greater than 30, blood pressure less than 90 systolic, and the 65 for age greater than 65 years. A patient is awarded 1 point for each of the features that they have. The points are then added up. A score of 2 may be considered good reason for admitting the patient, while a score greater than 2, or between 2 and 5, should be managed as a severe pneumonia. First of all, community-acquired pneumonias. These may be split up into those caused by typical organisms and atypical organisms. Typical causes of community-acquired pneumonia account for 85% and often present with the typical features that we've already described. The most important organisms are STREP pneumoniae and HAEMOPHILUS influenzae. However, others that have particular associations include M. catarrhalis, associated with smoking, and Klebsiella pneumoniae, associated with alcoholism. So, Strep pneumoniae. This is a gram-positive diplococci that causes an acute onset and often severe pneumonia with lobar consolidation. It is almost always penicillin sensitive. Haemophilus influenzae are gram-negative rods and are more common with pre-existing lung disease. It is also important that many of these organisms produce beta-lactamase that can break down penicillins. STAPH aureus, or gram-positive cocci, is not a common community-acquired pneumonia, but may present in elderly patients from nursing homes. It often occurs secondary to influenzae and likes to form pus, resulting in cavitational areas on the chest X-ray, which may represent abscesses, as well as empyema in the pleural space. The atypical pneumonias comprise around 15% of community-acquired pneumonias and include Legionella, MYCOPLASMA, Coxiella burnetii or Q fever, Chlamydia psittaci or psittacosis, and BORDATELLA pertussis. Additionally, tuberculosis may be regarded as another community-acquired pneumonia. However, this is often considered separately. Mycoplasma pneumoniae as an organism is interesting as it lacks a cell wall of any kind. Typically, Mycoplasma pneumoniae epidemics occur in young adults in their 20s every 3 years, and the clinical picture is usually fairly abnormal, For example, chest x-ray may be clear, white cell count may not be raised, and there may be a number of autoimmune phenomena associated with cold agglutinins, such as hemolytic anemia, splenomegaly, and carditis. It is usually sensitive to macrolides. Legionella pneumophilia, or pneumonia, occurs via aerosol spread, typically following environmental breakdowns in hotels and conference centres. While Mycoplasma pneumonia is usually diagnosed by serology, Legionella is diagnosed by antigens in the urine or the serum. Legionella is associated with a quite severe systemic illness that may include abdominal pain, diarrhea, lymphopenia, and hyponatremia. Like Mycoplasma, it is also sensitive to macrolides. Coxiella burnetii and Chlamydia psittaci are both zoonoses. Coxiella is obtained from domestic or farm animals and transmitted by aerosol or milk. Diagnosis is by serology, and the infection is sensitive to macrolides. Chlamydia psittaci is spread from birds by inhalation and also is sensitive to macrolides. Bordetella pertussis causes whooping cough in unvaccinated children. Viral community-acquired pneumonias can also occur, and these include influenza A and B, occurring on a seasonal basis, and causing primary pneumonitis or secondary bacterial pneumonia, and also varicella zoster virus and herpes simplex virus, causing pneumonitis in adults, and of course SARS. So now I'm going to go on to talk about some of the hospital-acquired pneumonias. These are defined as pneumonias occurring greater than 48 hours after admission. They have different characteristics to the community-acquired pneumonias. For example, the bugs are very different because of the hospital environment and any selective antibiotic resistances that have built up. Patients are typically different in that they may be very ill and immunosuppressed. And also the environment is an enclosed one, with patients usually in fairly close contact with each other. Most organisms are gram-negative and multi-resistant, and include Klebsiella, Serratia, Enterobacter, and Pseudomonas. There are 3 important antibiotics that are used. These are ceftazidime, which is the only cephalosporin active against Pseudomonas, gentamicin, which has good gram-negative cover, and vancomycin for any gram-positives. I'm now going to consider 2 important infections that occur in immunocompromised patients, such as those with HIV, or have undergone chemotherapy, or other immunosuppressive treatments. These are opportunistic infections and include Pneumocystis carinii and the fungi Aspergillus fumigatus. Pneumocystis carinii is a fungi that's found ubiquitously in the environment. It typically presents highly insidiously with a dry cough, shortness of breath, general malaise, and has a typical bat's wing appearance on chest x-ray. It may be diagnosed via immunofluorescence after bronchoalveolar lavage and is treated with Septrin and cotrimoxazole. This drug contains sulfamethoxazole and trimethoprim, both of which are folate antagonists. Aspergillus fumigatus is another fungi that causes 3 distinct clinical syndromes. The first of these is allergic bronchopulmonary aspergillosis, which causes an asthma-like presentation with chronic wheeze and eosinophilia. The next presentation is aspergilloma, which is when there is a fungal ball or abscess within the lungs. Interestingly, this may present with hemoptysis when it erodes away lung tissue. The last is invasive aspergillosis, which occurs most commonly in immunocompromised patients and associated with a very high mortality. This is treated with amphotericin B. So the final part of this podcast is going to be on tuberculosis. Tuberculosis is caused by Mycobacterium tuberculosis, which is a gram-positive intracellular bacillus, which lives in macrophages. It is thought that up to one third of the world's population is infected with latent tuberculosis, with the highest prevalences being in sub-Saharan Africa and India. In the UK, the highest incidence is in London in immigrant populations, probably due to some vitamin D deficiency in these people. There are a number of phases that we need to go through. First of all, infection occurs with inhalation of bacteria entering the lungs. Then there's primary TB, which is usually asymptomatic, where the TB multiplies in a subpleural focus called the GON focus, and is usually suppressed by a good cellular immune response. However, in immunosuppressed individuals, this may present as a pneumonia-like picture. The next phase is the latent phase, where the mycobacterium may remain for many, many years in pulmonary macrophages. If then, through either aging or the onset of another immunocompromising pathology, these mycobacteria reactivate, post-primary TB then results. The infection then becomes symptomatic, either causing pulmonary TB or disseminated or miliary TB due to hematogenous spread to virtually any organ. Pulmonary TB presents with apical shadowing and bilateral hilar lymphadenopathy due to apical cavitation. Important clinical features include a productive cough, general malaise including fever, weight loss and night sweats, as well as hemoptysis. The other condition to think about is TB meningitis, which is rare but important as it presents subacutely, often with no meningism signs such as neck stiffness or Koenig sign. Examination and diagnosis includes sputum microscopy, where there are acid-fast bacilli on Zeal-Nielsen staining, and sometimes culture, but this can take up to 7 weeks. Often, if sputum cannot be obtained, it's useful to do bronchoalveolar lavage or, in children, gastric aspirates. The MON2 test does not distinguish between BCG vaccinated patients and infected patients and is not reliable in HIV patients. This is important because 50% of patients in the world with TB are co-infected with HIV. The HEAF test is now largely historical. Obviously, the chest X-ray forms a vital modality in diagnosis and usually shows, as we've said, apical shadowing plus bilateral hilar lymphadenopathy. Treatment involves 2 weeks of isolation to make the patient non-infective. Usually this is done in a negative pressure environment with obvious safety control mechanisms in place, and with 4 important drugs: rifampicin, isoniazid, pyrazinamide, and ethambutol. Each of these has specific side effects that it's important to be aware of. Rifampicin causes altered liver function and induces cytochrome P450, as well as causing orange secretions. Isoniazid can cause peripheral neuropathy, which can be treated with pyridoxine, and also hepatotoxicity. Pyrazinamide also causes hepatotoxicity, and ethambutol is associated with visual disturbances. Following these 4 drugs for 2 months, only rifampicin and isoniazid are used for the remainder of 4 months of treatment. It is important that contacts of TB patients are followed up with MAN2 testing and chest X-rays, and they should be given isoniazid and rifampicin. Lastly, I'm going to talk about empirical choices of treatment in community-acquired pneumonia. These empirical choices usually lie along the lines of typical versus atypical agents. For example, for strep pneumoniae and Haemophilus influenzae, the most useful agents are the beta-lactams such as amoxicillin or cefuroxime, a second-generation cephalosporin. For the atypicals, Legionella, Mycoplasma and Chlamydia, which are often sensitive to macrolides, clarithromycin or erythromycin may be used effectively. Therefore, for a patient coming in for whom the precise organism is not known, the most usual choice is amoxicillin and clarithromycin or erythromycin. However, this of course varies according to hospital policy from different sites. So this completes the podcast on pneumonia and TB.